Hello and welcome to the 27th Degree with Chris and Nancy. Today we have a return guest, one of our favorite guests, Dr. Anna Cojocaru, who joins us today for a discussion on shortness of breath. Before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a 5-star review. They are greatly appreciated. So why don't we get right into this? So it's so good to have you back again. Thank you so much. This is like, I think, the third time you've
I don't know.
Yes,
third time? Third time, yeah.
Yep.
It's always great to have you.
Thank you.
And our audience really enjoys it too. You're always so full of knowledge. So we're going to talk today about shortness of breath. And just for those who have not seen you before, maybe you can just talk a little bit about your background so they understand where you're coming from.
Yep. So I'm Dr. Anna Cojocaru. I'm a pulmonary and critical care physician. So I'm a physician of the lung, takes care of people who have breathing issues. And another specialty I have is critically ill patients, the sickest patients in the hospital. But in the office, I take care of patients with lung problems. So shortness of breath is a common complaint that I see patients with. So.
And you have a shortness of breath clinic.
Yes, we have a dyspnea clinic or shortness of breath clinic where I basically, with my colleagues, but I established this when I started here in this community over 9 years ago, a shortness of breath clinic, because a lot of the times shortness of breath is being dismissed. Mm-hmm. We as physicians sometimes dismiss the patients if we don't find like a very obvious reason, and we dismiss the patients, and patients unfortunately continue to suffer with a sensation of shortness of breath and feel uncomfortable. And to me, that is more of a letting down your patients. I treat patients and evaluate patients with any reasons of shortness of breath. Mm-hmm. If they feel short of breath, we can see them and figure out what's happening. And sometimes we may come to the conclusion that is nothing organic in there. Yeah, it can be deconditioning. It can be how we say it in the head. But we should not say it's in your head until we dismiss.
You got to rule out all the other
stuff. The important things, and we can teach the patients. You may be deconditioned. These are the things that you may need to do, and education is important for patients.
That's always a tough one for patients to swallow. They can be, obese, obviously deconditioned, and it's hard for them to believe that's the reason for the shortness of breath. But we see that a lot in primary care.
I can get deconditioned too.
Yeah, of course.
We all can get deconditioned.
Of course.
What are the common causes for shortness of breath that you see most often?
Yeah. So cardiopulmonary diseases, we're having heart and lung problems, that can cause a lot of shortness of breath. But the way I look at the shortness of breath is, looking more for a physical aspect. So let's look at someone's body and look at the airways, where the windpipe starts, So it starts in your mouth, nose, throat. It goes down into the big windpipes, your larynx, and then your trachea, and go down, So shortness of breath, some people feel short of breath when they have sinus problems. Just because they cannot, sinus problems and nasal congestion, they cannot breathe through their nose. They just breathe their mouth breathers, and they can have shortness of breath from that. In fact, we're supposed to breathe in through the nose. And one of the things that, a lot of us don't know, but we learn, and I like kind of fun facts, our sinus cells inside, they produce this nitric oxide. Mm-hmm. It's a natural, it's a natural element, it's a gas that we produce, cells produce that. And what does it do, nitric oxide? It actually vasodilates your blood vessels in the lung. So when you take a deep breath through your nose, you actually takes away shortness of breath. So if you cannot breathe through your nose, in my view, you don't breathe in that natural, and you get air and oxygen from the environment, and you can suck in that nitric oxide a little bit in the air to keep your blood vessels in your lungs dilated. And vasodilatation, or your blood vessels in the lung, when they relax and dilate, that takes away shortness of breath. So you can have shortness of breath from nasal congestion and sinus problems.
That's interesting because I have patients come in all the time and they say they have a deviated septum or something that's affecting their nasal passages, and they complain of shortness of breath. I always found it odd because you can breathe through your mouth.
Yes.
That makes sense now, doesn't it?
Yep. And we need to breathe through the nose. It's better that way. It filters everything, It filters everything. It actually, the air and warms up the air as well, So warmer air is good for our lung. We don't want to get cold air in our throat. So obstruction in the back of the throat, it can happen, cancers, or even gaining weight and having obstruction in the back of the throat from, extra tissue. Anemia, can cause actually shortness of breath. Thyroid problems, when you have big masses in our neck or in our chest. Muscular problems, your chest wall problems. So if your rib cage, the lung is inside a cage, and we don't realize that. And that cage needs to be really flexible in order for lung to work, Because if our rib cage is very stiff, we cannot ask the lung to do a good job when it's so stiff, because you're like constricting the lung and when you expect the lung to work. So patients come to us and they have completely normal PFTs, or they're considered normal. And you look at them and they tell you, listen, I have shortness of breath when I bend forward, but they have a big belly. Or when they take deep breaths, they feel like they cannot take that deep breath in. So the sensation of shortness of breath can be different. And actually some people say they feel tightness. They feel that they cannot they feel air hunger, They feel like at the end, they cannot take deep enough breath, or they feel like it's not a satisfying breath.
So you're like an investigative reporter almost.
Yes.
Like someone's coming in and you're taking a quick assessment of them visually, and then you're digging deeper.
Yes.
So what
when I listen to their lungs also, I ask them to take deep breaths on the bottom, even your diaphragm, that's the muscle that separates your belly from your chest. And we know that the belly, if it bulges out in front of your belly, just when you see it right here on the clothes, it can push up on your lungs as well. And it pushes into your rib cage, which is stiff. So, and also what we know over the years, and I see in a lot of elder population, we shrink. And where do we shrink from? A lot from the spine. And that means that you're going to shrink your thoracic cage. Yeah.
Oh, yeah.
Yeah. So you can have losing lung function over time, problems in the windpipes, problems in the lung blood vessels. We have blood vessels running through your lungs. But what is important to me when someone comes in my clinic and when they go to the emergency room or they're very short of breath, I need to think, is it anything that then can kill this person right now? So the first thing is to look at their signs and symptoms. I look at them if they're in distress. I look at them if they have, blue lips,
right.
If they look pale, like they're going to pass out, if they have blue tips, fingertips, that's lack of oxygen, So those are the things. And sometimes lack of oxygen over time will give an unusual shape of your fingertips, or is called clubbed fingertips,
Right.
And that there are signs. I look at the person. I can do a full, quite good exam just looking at you and talking to you. Without touching the patient.
So let me tell you, as a primary care doctor, how I think about shortness of breath. Tell me how I'm doing here. Tell me if I'm doing okay.
And be brutally honest.
Yeah, you can be honest.
All good,
So basically, this is a very common complaint. We get this all the time. I probably have patients come in, maybe not every day, but
it's very common,
close
actually.
to that
yes.
with this complaint. So the first thing I always think about is there something that is fatal?
That's right.
I don't want to miss something like
That's
that,
right. Yep.
And then I break it down into cardiac reasons, pulmonary reasons, then the other stuff. And the other stuff is like anemia and things like you really don't want to miss, because it's so embarrassing if I were to send someone to you and they had an anemia as the cause.
Don't you worry, it happens to us too.
That would be really embarrassing. So, there's blood work that I check to look at that. But as far as the cardiopulmonary causes, cardiac, I'm always thinking, is this due to, coronary artery disease, myocardial ischemia? Do they get symptoms when they're exerting themselves? Are they wheezing? Do they have COPD? Do they have asthma? Were they a smoker? Did it come on suddenly? Could they have a pulmonary embolism?
Do they cough?
That? Yeah. Do they cough, etc.?
Yeah. So wheezing and coughing will be symptoms of airways disease.
Yeah.
And do they have a stridor? You pay attention to that. They come to you and they're like, you're like, okay, this is something bad. Okay, it's not good.
Yeah.
Or they cough nonstop and they cannot catch their breath. These are the things that we see. Yeah, but that's important. And then you do spirometries probably in these patients. And spirometry is not only looking at airflow limitation and thinking if they have asthma or COPD. In fact, there's a curve. They give us like a triangular kind of curve. And actually that shape of a curve can tell us if there's upper airway obstruction, for example. Yeah.
Doctors, how important is it to know someone's baseline? To know, to look at the changes that are
very important. And, when I have patients who complain of shortness of breath and they have a normal test, but some things are borderline, like today I had a patient. The numbers, except for gas exchange capacity, was over 100%. But gas exchange capacity is 80. 80 to 120 we consider normal. But it's 80.
Right.
Okay? So I say, it looks okay, but let's repeat this. And, symptomatically you're doing okay, but let's repeat this and make sure, because I don't know, maybe she's now short of breath, but I don't have a test from 10 years ago or even 2 years ago.
Right.
And her gas exchange capacity maybe at that time was 120 and now it's 80. Okay? So the change is important. Absolutely. And that's why when they complain of shortness of breath, I had a patient who came to me, after having COVID, never had issues, a young patient, breathing test was completely fine. And he went into the community. 6 months later, he was seen by rheumatology because he had muscular weakness. So it was kind of progressive. So this shortness of breath, sometimes it can be associated with fatigue or weakness, and people will get fatigued and tired.
Right.
And they think that they're short of breath, but there's actually tiredness. And he was diagnosed with a rare myositis, that's a muscular disease, connective tissue disease. And the rheumatologist contacted me and said, I want you to see this patient back because this type of myositis is associated very frequently with lung involvement. And I want you to repeat the PFTs. And this is where we doctors, communicate. So I got him back to repeat the PFTs and to do, to make sure that we monitor that patient and put on the right medications and treatments.
Right.
So how does someone at home know, at what point to go see their physician, or just tough it out? I'm a little bit short.
So I do not agree. I do not agree with toughen out.
Yeah, why would you do that?
Because, for instance,
patients do that, but patients do that.
My husband, who had pulmonary emboli, didn't know it. He was out in the yard doing yard work, and he's like, "Oh man, I'm really out of shape."
Well, I think if there's something that seems very different than your baseline, or you're really symptomatic, you should be seen. There's no reason to tough it out, so to speak.
Yes, but patients toughen out. She's
They
right.
do.
Nancy's right. They tell me, Doc, I thought that is going to go away. I just want you
that's
to
pretty common.
let it go. It's like Portuguese man or even,
Exactly.
Eastern European where, they want to toughen out because they think that, it's okay. It's just a cold. But then any kind of cold or any kind of symptoms that's unusual, it can be something worrisome. Yeah.
Of course.
So in what worries me in patients is something really, there are some worrisome signs, yeah? Mm-hmm. If you cannot breathe, that you feel, oh my God, it's out of a sudden, and you feel like you're going to pass out, you cannot catch your breath, you cannot, you feel like you need to sit down and kind of take a break from what you're doing, that's significant.
Okay, that's great.
You need to really reach out to someone. If you have an underlying lung problem, I usually, or patients who have, any kind of, I have a proper diagnosis, I teach them action plan. And I think that every patient with airways disease, who have asthma or COPD, need to have step 1, step 2, step 3, what to do in case they get winded and they get out of breath or they have additional symptoms, increased cough, wheezing. They need to know. I cannot tell them, call me right away, because right away, I may not get an answer right away. I may call them back in an hour or two. Mm-hmm. They need to have rescue inhalers. They need to have nebulizer machine. They need to have medications that they can use in that. They're not, from 5 years ago when they come to my office, do you have medications enough of nebulizer treatments? Do you have a maintenance inhaler? Yeah. When to use and what to use. Do they know to use the Mucinex? Do they know how to use that inhaler? It's very important. You know how many patients don't know how to properly use an inhaler? And they're wasting it. And they need to know if they can use more or not. Yeah. Use it once or twice a day. And how much is too much? Or just use albuterol like 5 times a day for like 10 days in a row. That's really bad. If you have asthma and you do that increases mortality.
Doctor, when someone with asthma that's being, I don't want to say managed by their primary care physician, it sounds like there's like a lot of education that they need to have. So where do they get that education past like what the PCP may say to them in general?
I think that patients who have asthma all their life since childhood, they get education. Yeah, they get some degree of education. Nurses can educate them. Respiratory therapists, when they do breathing treatment, can educate them. Allergists educate them, pediatrician, primary physician. But what's important in asthma, number one, is to avoid triggers. When you know your, for example, most common type of allergic or asthma from childhood is allergic asthma. Yeah, you can have a specific kind of phenotype or a genetic predisposition. Yeah, some deficiencies or increase the eosinophil counts. That's a type of inflammation that comes with asthma. Or you have environmental allergies, increased IgE, and then you need to know your triggers and avoid triggers. Environmental changes are very, very important, and to me, that's cornerstone of treatment. They tell me they have a cat and they're allergic to the cats. Okay, maybe they cannot get rid of a cat because they're waiting for the cat to die. But you know what? They can make still some changes. And the changes may be that the cat doesn't come into their bedroom.
Right.
Yeah. We sleep in that bed and in that bedroom probably at least 6 hours a day. And avoiding to have a cat in your bedroom and not going over your face will be an important thing, yeah?
Right.
And also if you get exposed to cat and you play with a cat, how about just washing your hands before you touch your face? How about using some saline nasal drops or rinses to get rid of mucus and any of those small particle allergens, small things that we breathe through the nose and stay in the nose right there to trigger our inflammation.
Right.
Just get rid of it. Yeah, if you're allergic to dust mites, which is very, very common, dust mite allergy, yeah, you should not have in your bedroom carpets. You should not have a lot of, covers for your bedding, and it needs to be washed really in specific treatments have to be done during washing. Dust mites were small little kind of organisms, little bugs, let's say,
they're really
invisible.
nasty looking under a microscope.
You cannot see them, but they live on our clothes. And guess what? They survive washing. So you need to use to wash your bedding, and I tell my patients hypoallergenic covers, but also they like to go on natural feathers. So I don't want them to have any feathers in their bedding, okay? Any pillows with feathers. No down, yeah. And they need, as I said, they can survive in washing, in the washing machine. So you need to use everything extra and double, okay? Extra hot, extra long, double detergent, and do extra rinse.
So it seems
and you
like
extra hot. So this is when actually there are studies in that showing that it decreases the load of dust mites in the washer machine and in the clothes if you do it this way. And decreases. I've had patients who transformed their life by doing small things like that.
That's
Environmental
a huge issue with
changes, rinses for the nose, making sure they have a nebulizer machine. Because I'll tell you, you can have asthma and they use all inhalers, they get asthma attacks. And to me, if you have bad asthma or COPD, airways issues, and the inhaler is a small puff, and the way you puff it in and suck in that medication, if you're wheezing or coughing, you'll cough it right out.
Right.
That medication will never make it into your lungs. So you need that nebulizer. It's a longer treatment that takes 5-10 minutes. No matter how bad you cough, how much you wheeze, that medication will make it deep into the lung, release those constriction, the tightness in your chest, and allow you to breathe. And then after that, you can get some treatments. Actually, albuterol, which is a windpipe opener, is just a Band-Aid, temporary Band-Aid. You open up to calm down the cough, to decrease the wheezing, and then I want you to use the inhalers that actually heals you. Now I want you to get inhaled corticosteroids.
So there's
now
an order.
That's right. That's an order. I actually have a way to tell the patients, you start with this, you do that, you do that. And yes, sometimes you can use more of your inhaled steroid from the baseline, which is, maybe 1 puff twice a day or 2 puffs twice a day. Yeah. It's okay to use extra sometimes if a doctor tells you that, and they'll tell you when and how. Yeah.
Right.
And if you have fevers, if you have coughing up blood, that's very important. Don't wait. Oh, I just always cough up blood. It's not normal. That's not normal.
So you talked about the environmental triggers. What about seasonal triggers? Like now we're going into the winter. Are there things that people should kind of watch out for? Are there certain things that you see?
Seasonal will be mostly, viruses and respiratory illnesses. We have so many respiratory viruses, and we know now in our hospital, we do have some COVID, some variants of Omicron or BA5, whatever we have right now is not so bad. But we do have a lot of RSV and a lot of other respiratory viruses from influenza, rhinovirus. And in my view, I was last week at the hospital, everybody who comes with an upper respiratory infection, we do a whole panel with like 10, 15 viruses. I want to check and make sure that we isolate them, everybody washes hands, and we don't transmit it to others, but also tell them and their family to make sure that they don't transmit it,
Right. Are you seeing a lot of flu too?
I haven't seen much flu. There's a little. It's mostly RSV I'm seeing.
RSV, yes.
RSV has been pretty prominent in the community.
Can you talk just a little bit about RSV? Because I know people have heard it in the news and everything, but I don't know that they know exactly what it is or if they should be worried.
RSV is a common cold virus, that is known to cause significant problems in infants and actually very little children because their windpipes, so if you imagine the lung like a tree upside down with a big trunk here in the chest, in the middle, and then goes to the left and right and then divides like a tree, the little windpipes can get very little clogged with mucus. So RSV and a lot of viruses, it actually triggers inflammation into your windpipes, and your cells that line up your windpipes, their protective mechanism is to produce mucus, so it clears that mucus will bring up, so it forces you to cough to bring up a virus and get rid of it. So this is a cough, and mucus production is a protective mechanism for your lung. Yeah. So when you start having those, it's like something is wrong. My body's telling me I need to get something out to clean my lung. Yeah.
Right.
But kids who have very tiny windpipes, they clog their windpipes. So their tiny little windpipes get clogged and now they cannot move air. It's like, imagine like the tree, they have little branches and the branches kind of die off and they fall off. Yeah. And we see that actually in bronchiolitis and allergic asthma as well, where they have small airways disease. And that is very difficult to treat, unfortunately. Yeah. But, in kids, in small kids, it can cause respiratory distress and basically to windpipe and respiratory failure. And in older people who have multiple problems, because their immune system is decreased and if they have underlying lung disease or they have, other reasons to have inflammation in their lung. Maybe they have bad reflux and they aspirate time to time. Yeah. Maybe they have congestive heart failure. And guess what? Congestive heart failure is a reason to get what we call reactive airways and windpipe swelling. You can get wheezing and windpipe swelling from congestive heart failure. You don't have asthma, but you wheeze. Yeah. Is albuterol going to help? Yes, it's going to help because it releases a little bit of bronchoconstriction that you get from windpipe swelling. Windpipe swelling from extra fluid in your lung is going to cause the muscle, the respiratory muscle, the smooth muscle that we have around windpipes, is going to cause that muscle to constrict, to tighten up. So if you give it albuterol, it's going to release that, but it's only temporary. So if you have congestive heart failure, for example, and you have a little bit of windpipe swelling, a little bit of reactive airways because of that, and you get RSV, now, it's something else to inflame that windpipe.
Right.
Yeah. And it can be as simple as that.
Sometimes with the, with patients who have COPD and they have heart failure too. It's so hard to tell the difference. Sometimes we
Yes.
end up treating both.
Yes,
You can't
and
tell.
and unfortunately, advanced COPD can cause right-sided heart failure.
Right.
And they come and they're like fluid overloaded, and they have a COPD exacerbation.
You treat both.
You teach both.
Yeah.
And also, what do we know? Patients with bad COPD, for example, when they get hospitalized, they're so bad that they need to go to the emergency room in the hospital. They have a higher rate of pulmonary embolism, blood clots. They have a higher rate of heart attacks. Yeah, because it strains their heart. When you cannot breathe, the heart and lungs are in this rib cage, in this fixed, let's say, some elasticity. Some people have more elasticity than others, and that actually can impede your capacity to clear infections, to allow the body to work properly. If the heart is being constricted as well, it's like constrictive pericarditis, The lung can be constricted by rib cage, by big abdomen, and then you have the heart and lung in trouble, then you're falling apart. It's very common that we see it. But I think knowledge, and what I will tell you today, I saw a patient in follow-up, and she came in with tests, and we did like a swallow evaluation. I'm like, oh, it shows a small hiatal hernia. Oh, we did the testing for you, and it shows this, some allergies. And she's like, Doc, she felt so good by understanding that she has a little bit of hiatal hernia and the fact that she has a little bit of allergies. Like, I noticed that I'm like sensitive to mold. And every time I get into a moldy home or in someone's house, I feel it that is bothering me. And it made sense to her. And just to allow the patient to understand these are the things that can trigger your breathing issues. And, you just watch out, just makes them feel better.
Yeah, because I think sometimes if a patient goes to their physician and the obvious things aren't found, it's kind of labeled as, psychosomatic or whatnot. And
you know what? I had a bunch of people coming and, psychosomatic, and we found rare diseases, including pulmonary hypertension. And then we look really, oh my God, I wish nobody would have said that you have this psychosomatic.
That's my point. I mean, I think that if you go to your primary care doctor and it's not obvious what the cause is, then go to a specialist.
Yes, go to a specialist. Yeah. That's why,
because there are things that we would not normally think about.
That's right. And and nobody in medicine is so deep now and is so much information from genetics to a lot of things that we cannot know it all. And I tell my patients a lot of the times, listen, I don't know, but we'll try to figure it out. Yeah. And I ask for a lot of consults as well. I don't know. I send it to infectious disease. I find an infection. I can read the book to put you on medications, but it's not right because I don't treat that kind of infection very often. Or even a rare pulmonary disease, I don't treat them alone. But always I refer and I want them to go to a tertiary care, and then we can co-manage together. Some patients refuse to do that.
Sure.
Yeah, but that's different. It's better for us to have another set of eye to look over.
It's a team effort.
It's a team effort.
There's a lot of things that are very complex in medicine, no doubt.
Yes.
But I think what I'm hearing, just to summarize a little bit, if someone has shortness of breath, this is what I'm hearing, just for our audience out there. One, don't tough it out.
Don't.
You know, if you perceive that there's something going on with your body that is different than what you normally experience, go to your doctor, go to your primary care doctor first. And then you should expect that you'd have a fairly typical workup, which would mean a thorough history, a decent examination, maybe some blood work.
Yeah.
And then usually for me, I do a chest x-ray and some pulmonary function tests.
Yeah.
And if it's not apparent through the history and the exam and that limited testing, then refer to a pulmonologist who deals with shortness of breath.
Yes. You can give them an inhaler as a trial.
Mm-hmm.
That's okay as well because, especially if they have symptoms like wheezing and cough, and asthma and sometimes chronic bronchitis. Chronic bronchitis and asthma is a clinical diagnosis. Mm-hmm. To put actually COPD or emphysema, it needs a spirometry. But you can make a clinical diagnosis and put them on an inhaler as a trial, make sure that they know how to use the inhaler. But then if they don't get better or they get better and they get sick all the time, recurrent issues, that needs a specialist overview.
Right.
Yeah, recurrent issues, because recurrent issues can damage your lung, each time, and you can get less lung function. Years ago, we didn't have so many treatments for asthma, for example. I just keep talking about asthma because asthma, unfortunately, still kills a lot of people. And it still kills people in our community and young people and teenagers and people who have a whole life ahead of them. And it's very sad. Asthma education needs to be out there so we can get people better. But I had patients, we didn't have so many treatments for asthma. So I have 70-something-year-old patient who had just allergic asthma all her life. Her lung function is 30%. Just because we did not have treatments, okay? And now she finally got on treatments and she's like, since I started this immunotherapy 10, 12 years ago, I feel so much better. But the lung damage was done in childhood. And now I feel like if children are not controlled or young adults, they need to be seen by a specialist. And I'll tell you, I've had a patient who came in with chronic bronchitis from community a few years ago, and I do different testing, including alpha-1, and I found he was an alpha-1 patient.
Yeah. And just for the audience, so they understand what that is, that's a genetic condition that increases the risk of COPD and basically
definitely lung cancer and infections. Yeah. And this guy, thank God, was not a smoker. Yeah. He was not a smoker. And he comes once a year to see me, and he doesn't need any specific treatments, just he needed education. And to get to know what to do, with his underlying, yes, he has chronic bronchitis, but the reason is a genetic problem. And then, we need to monitor his lung function and genetic testing over family members like children and stuff like that. But, these are simple things that we as specialists do and helps also. I hope that patient will be helped also. I tell him, he has 2 young children and his wife actually came with him to the appointments after a few times saying, your children should be educated. They may inherit this and they need to make sure they don't get exposed to anything in the environment, like they shouldn't smoke and they should not be firefighters or hairdressers, and like don't do the jobs that is going to get you in trouble down the line. Yeah. You want them to be happy and healthy, yeah?
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
It's interesting that you said hairdressers because they use all the chemicals.
Yeah.
Yes. They're better now, but we do have a lot of airway problems from the exposure to small chemicals and perms that they used to use. And
Airway disease and carpal tunnel. Those are the 2 environmental factors that we see with hairdressers because they're always using their hands.
Yeah.
You get a lot of carpal tunnel.
I just never thought of hairdressers as being prone to
very dangerous job.
40 years ago also, in this area was the women who were working in the factories, in the textiles, specifically the ones who were cutting cotton. It's called babiosis. Right. It's an interstitial lung disease from small fiber of cotton that get deposited in the lungs. So we see it time to time in an old lady and they're like, I wonder if it's babiosis. We can say, some changes, ILD changes, interstitial lung changes on the CAT scan, or sometimes we don't do much about it, but, it's from the textiles in this area. And actually when I learned during my training, at UMass many years ago, they actually used to say, textile people from Fall River. Fall River women who used to cut.
Oh my gosh.
To cut but in textiles. Right. They have a specific disease.
Yeah.
And I think a lot of people too who've worked in factories, they've been exposed to a lot of other agents like asbestos, and they're not even sure I had a patient come in the other day. He had shortness of breath, and I did a chest X-ray, which was grossly abnormal. It looked like asbestosis. Mm-hmm. And the CAT scan was recommended, which I did, which supported the diagnosis. Yep. And he had absolutely no idea how he was exposed. None at all. Yeah. He's going to be coming to see you or one of your colleagues.
Yeah. I had a patient like that who had actually didn't have much, a little bit of changes, but he had, and he remembers very well, he developed mesothelioma, which is a complication of, asbestos exposure. You can have these plaques on the lining of your lung and then develop a cancer of a lining of a lung, which is very, very bad.
It's a bad one. Yeah.
But he basically, what he remembers, he built his own house or his brother's house, and they did their own insulation with asbestos. He remembered that.
yeah.
Boy.
Yes.
Oh, that was a tough one, huh?
Yes. And he got probably that from, trying to build their house, and, it was like
Oh,
50 years ago.
Yeah.
oh my
Yeah.
gosh.
It's sad, isn't it?
The other thing you see a lot of times, people are always amazed that they have COPD and they've never smoked.
Yes.
And I try to explain to
Environmental COPD.
What's that?
Environmental.
And just part of the aging process
right.
and all of that. I
Yeah.
mean, our lung function does decline like most things as we age.
Yes.
We're at
And then
risk of
secondhand
developing
smoke exposure. Yeah.
Right? Secondhand exposure.
Yeah. We know that children and fetuses that are exposed to smoking in their mom's belly, moms who are smoking, they have smaller lungs. If you're born premature, one of the things that I ask sometimes, I was a premature, your lung is not developed, yeah? And when your lung develops until the age of like early 20s, if you smoked before that age, you didn't allow your lung to develop fully.
Really?
If you're exposed to secondhand smoking in your household because parents used to smoke in the house, you are more predisposed to have asthma, reactive airways, recurrent infections. So secondhand smoke exposure in childhood, very important.
Do you still see a lot of smokers? Has the number of people who smoke gone down? Is like, what do you feel like? I know you might not have stats.
Yes, I don't have statistics right now, but in Massachusetts is considered a lower rate of smoking in general, but this area where we are, New Bedford
Yeah.
Fall River,
Yeah.
is actually one of the highest in Massachusetts,
sure.
one of the highest in the country. Here in the western Massachusetts, in
I
Springfield
think
area.
I see less than I did years ago, but it's still surprising to me that there are still younger people who pick up the habit.
Yes.
Yeah.
Because
Yes.
there's so much information out there now. It's not not like, my father who picked it up before, the Surgeon General came out with their warning and he smoked for many years and then gave it up, probably it was the 1980s. But the point being, there are younger people now who are picking up this habit, and
Yes.
it shocks me.
Yes.
Is some of the damage reversible if people have smoked for a number of years and then they stop?
It depends what of the damage was done. So I tell the patients, if you think of a lung like a tree upside down, so you have two big components there to think. Is it the windpipes that have been affected? Okay. So the windpipes can be affected and swelled up. Inflammation and swelling can go down. Okay. But once I tell them, if you have a cut on the skin and you keep rubbing it and you keep irritating it, what do you get on that skin in that area? Scar tissue. And like a scar, yeah? And when it tightens up, so this is what happens in the windpipes as well. Recurrent inflammation will cause some degree of remodeling, how we call it, in the airways. So you're going to have now fibrosis of a windpipe. So more windpipes that will be more stiff and less flexible. So some degree of reversibility is there if you can decrease the inflammation, if you have a lot of mucus. But then once you get to that scar tissue, there's nothing we can do, okay?
Right.
And then the second one is emphysema. So if you look at the lung, so windpipes can be reversed to some degree, okay? And then emphysema is the lung at the end of each windpipe or these branches, you have like a sponge, yeah, where the oxygen exchange, alveoli, yeah? And it has to be very dense sponge with tiny little holes, yeah? And emphysema is when the lung is being destructed and you have like big Swiss cheese holes, yeah? Once the holes are done, there's no repair that is going to be happening. So the lung does not repair itself. There's a lot of studies and a lot of, and animal models. They're looking to see if any stem cells that can regenerate lung. There are studies looking at that, even in pigs, and I know University of Vermont is doing that. And they're looking to get to regenerate the lung, but at this point we don't have any at this time. So if you have bad emphysema of holes in the lungs, you got it. We're not going to reverse. But we'll be able maybe to heal the windpipes to allow that air to come easier in and out.
Let me ask you this question, because there's so much of this out there now. I mean, we know that tobacco has a very adverse effect on lung function and lung health.
Yep.
How about marijuana? There's so much marijuana being smoked out there in our community
Yes.
and throughout the country.
Yes.
What is the
So-
long-term effects of that?
So any kind of fumes and smoke that we put in our lung can affect the heat the combustion of that, it can affect your windpipes and can cause inflammation. Marijuana, can be contaminated, so you can grow unusual infections in the lungs, and we've seen that. It can cause acute lung injury. Okay, some people get like an allergic reaction in their lung, and they can die from it. Okay, but there is some data that marijuana chronic use and long-term use can increase the risk of cancer, and it can cause windpipe problems, and similar to COPD. We don't have very clear data, but it can cause cough, it can cause wheezing, it can cause inflammation. So guess what? It can cause a lot
I think there's a general sense with many people out there that it is not harmful, but this clearly is.
Anything that you breathe in that is heated and, it has some combustion in it, it can affect your windpipes.
That's interesting.
Yeah. And even the dust that we inhale, it can cause problems.
So preventatively, is there something we should be taking over the counter for our respiratory health? Just switching gears up a little bit, like especially going into the winter when people tend to get like more of those colds that may last and stuff.
Yeah.
Is there like a magic bullet solution out there?
So, you have to have strong immune system in general. That applies for a lot of things. But I do believe that healthy foods and, fresh veggies and fruits and green stuff, it can help, and because they have vitamins, they have zinc. So vitamin C is well known to boost up your immune system. Zinc for a few days, it may help to boost your immune system a little bit, but there's no magic bullet out there. You need to make sure that you don't overeat processed foods that can decrease your immune system. Healthy guts are important because intestines, our GI tract is like an immune organ. And in fact, the lung is an immune organ as well. Because what are our immune cells? These are cells that run in our blood and circulate throughout our body and go and scatter and go and just check everything out in our body. They have a little home, and their homes are usually lymph glands, But they're also similar to lymph glands. They are these little plaques that is found in the GI tract. What is the small Petri is some plaques. They're little like kind of lymphoid cells, that are along the GI tract. But also
like these lymphoid aggregates.
Lymphoid aggregates,
Yes,
exactly.
Right.
So that's why the GI tract is a good immune system, and eating healthy foods with increased fiber is important, and fresh foods, less meat probably will be good. But also the lung is one organ that the blood circulates through the heart, and then it goes and washes the lung completely. So 100%, in theory, 100% of your blood that circulates through your body goes and washes your lung. So every cell, or immune cell in your body that circulates, eventually is going to make it to the lung. So the lung is considered, and it is a very immune organ.
Right.
That's why respiratory infections, when people have recurrent infections, what are common sites for recurrent infections? Immunodeficiency. When your immune system is not working, there are two major things: skin and respiratory. They also get GI, I'm sorry. It's the ones that get in contact with external things. Skin, they're getting recurrent infections on the skin and, this boils and maybe rashes and stuff like that. Sinus infection, sore throat, and then GI problems. So these are the things that in respiratory infections are common actually in immunodeficiency. But good food, vitamin C, zinc supplement, but if you have really a respiratory infection with significant symptoms, you need to call your doctor. It's just better that way.
Absolutely.
Because getting easier, faster the treatments, if you have influenza, for example, if you give the antiviral medication like Tamiflu or others that are out there, you can actually decrease the length of your disease and recover earlier, not transmit it to so many people. The same with COVID. Do a home test for COVID. Call your primary. We have treatments for that. We get you better right away. You don't have to allow yourself to get downhill and then end up in the hospital.
I'm gonna
Even with RSV, there are treatments. But we don't use it for everyone just because it's not so accessible. But if you're at high risk, there are actually nabs that can be used specifically, antivirals in the hospital can be used, some pills for antiviral for RSV. So there are treatments.
Yeah, like a healthy adult who has
Yes.
RSV, who caught it from their kids or grandkids, and they
Usually are
minimally
okay.
symptomatic. I don't usually do
Of
anything
course
for,
not.
but
Yeah.
if they have underlying lung disease and that, or at risk for
Yeah.
hospitalization.
Yeah, and they come hypoxic
be
in your
treated.
clinic. I
Sure,
actually had a patient who came hypoxic in our clinic with
It
RSV.
comes back to don't be afraid to call your doctor and come
Yep.
in. It's
Yeah.
it's always good to get checked out.
Yes.
So what do you think are the most common causes of shortness of breath that you see in your clinic? Just so we can kind of summarize a little bit and you let the audience know what they, we're
Yes.
thinking about.
Yes. So lung problems as airway problems, asthma, COPD, and that usually comes with wheezing, cough,
Mm-hmm.
shortness of breath. Yeah. Second one is cardiac disease, even arrhythmia, where abnormal heartbeats can get
Mhm.
people to have shortness of breath. Yeah. Congestive heart failure, even angina, or having coronary disease. Some people don't have a chest pain or pressure, they have shortness of breath, especially if you're a female. Yeah.
Right.
So that can happen. Now, what things can actually get you in trouble is blood clots. So if you get blood clots, and that's quite common, I had a patient who came to me for a shortness of breath, and she's like, I have this sudden onset of shortness of breath. I passed out I was in the supermarket, I passed out, and I was short of breath, and they checked on me. They said it was a seizure. It was not a seizure because she had a seizure history. And I'm thinking, did they do a PE protocol? Like, you passed out, you got shortness of breath and chest pain. Blood clots can kill you, So those are the things that we need to keep. Do you feel dizzy at the same time? I would make sure that, and also what is troublesome, I don't see it very often, GI doctors see very often, don't eat and talk. Aspiration, big chunks of meat now with holidays coming, and they aspirate and it goes.
So common.
And when they die, people die from little pieces going into their lung. I collected from people's lungs,
Usually it's a piece of meat.
I got nuts. We got, nut shells out of people's windpipes and, a full nut and, walnut and pieces of chicken and carrots and
talking while you're eating is not a good thing.
No. And everybody can choke, My 13-year-old will choke because if she laughs with her mouth full. So
right.
Have to be careful.
So I'm going to ask a question that's going to make you cringe.
Uh-oh.
So I'm not feeling good, and Chris says, hey, here's some antibiotics that I didn't finish from last year. They're probably still good. Why don't
Should
you
not.
take a few?"
Well, I would never do that.
I know.
No.
But why is it not a good idea to even take your own, like, from leftover that maybe you didn't finish and you have a couple make you feel a little bit
better.
better?
The first thing that I will do if I'll have like an upper respiratory infection or feel like I'm getting a cold, you need to make sure that you blow your nose. You know how to blow your nose, get rid of mucus, okay? Use some saline nasal drops or washes. It needs to be done specifically. You cannot just use tap water because you can get infections from there. But you need to rinse your nose to get rid of a mucus. You can take some Tylenol, gargle your throat, get rid of an infection. You need to cough everything out. Use an inhaler if you have it. But call your doctor, You should not take antibiotic with viruses, okay? And then some antibiotics may make some things worse. And when you develop resistance, now you're going to have, some antibiotics will not work for you.
Yeah,
At one point.
I feel like patients are much more educated about that than they were years ago. I mean, in the past, antibiotics were given out so loosely for a lot of viral infections, and it was really to the detriment of our patients.
That's right.
Quite honestly. But I think patients are more educated. Doctors are clearly more educated now in regards to that.
Another thing that, misconception is people say that, I got a cold and they're like going under their covers and they're not showering. It's okay to wash and clean. Okay? Clean and blow your nose. It's going to get that steam. It's going to get you to open the windpipes. Some people, if you're not allergic to eucalyptus, but, some natural things like eucalyptus, it can actually help to vasoconstrict your nasal passages so you can feel like you're breathing a little bit better. But washing, you can wash those bacteria from your nose and throat, and it can be good for you.
What happens if it's like a wicked chilly winter day, is it harmful if you have like a cold or a brewing respiratory infection to go out in like really low number
So you're going to
weather?
get sick from being out in the cold, so to speak. That
Or
kind of,
like constriction with your
Well, that
You
can
can
be
get,
an
not
issue.
everybody gets bronchoconstriction with cold, but if you breathe through your mouth, it's like if you put your finger on ice, it's going to burn at one point, no matter how strong you are. Yeah.
Right.
So the same thing, if you breathe through your mouth and not through your nose and stay long enough, cold enough, whoever, then it's going to bother you. Yeah. It's going to hurt your throat from cold. You can get a little bit of inflammation there, but it's inflammation from cold. It's not from from an infection. Yeah.
Right.
You can decrease your immune system, I guess, different ways, and then we're all, filled with different bacteria. Yeah. So if you are, harboring in your throat strep, you can decrease your immune system by different ways, in different ways, and you can get a strep throat kind of flare up. Yeah.
Right.
If you have recurrent sore throats, you need to see your lung doctor or your primary doctor, or you see someone because you may have some immunodeficiency, very common, IgA deficiency. And these people will need just a pneumonia vaccine that can boost their immune system, and then they stop having all of these sore throats, Not all of them, but some of them, because it's not only from strep, but some patients will just say, since I got the pneumonia shot 10 years ago, and now I'm all good. And it's probably because you're getting strep throat. And we get the pneumonia vaccine is against Streptococcus pneumonia.
Yeah, makes sense.
That makes sense.
Interesting. Interesting.
So is simple things that can make a difference.
So we see a lot of people who also come in, they complain of cough. And it might be just worthwhile to throw this out there because it's an interesting thing in that a lot of patients don't realize that cough can be from acid reflux
Yep.
and asthma,
Yep.
and postnasal drip.
Yep.
And those
Yeah.
are probably the three most common causes
Yep.
of cough in a primary care office.
That's right.
That lasts more than, say, a month.
90%
Right.
of cough is caused by asthma or steroid responsive asthma, and the same asthma is a big category, and upper airway cough, which is reflux and postnasal drip. Yeah. And those are very common. Yeah. And you need to make sure that those are not the ones. Reflux can actually make your cough last longer after respiratory infection. So that's very common after you had, viral illness or something, and when you recovered and that the cough is lingering, is because your windpipes and you have this reflux. Reflux is not bugging you because you didn't have a cold. Now the cold irritated your windpipes to that level that now everything is going to put them on fire.
Yeah.
Right.
Yeah. So we need to treat everything simultaneously, kind of allow them. And of course, we use a little bit of Band-Aid in between. We need to calm down the cough so they can rest, so allow the windpipes to heal, and it takes a little bit longer. But if your cough lasts more than 12 weeks, that's abnormal. Yeah, it's chronic cough over.
Yeah, and I'm seeing a lot of patients, and I hate to even bring up this word, COVID, but a lot of patients who've had COVID and they have cough for months afterwards. I'm sure you're seeing a lot of that also.
Yes. And the cough, if it's for too long, then it needs to be really, after 12 weeks in theory, it needs to be evaluated. Chronic cough after 12 weeks is not okay. It should go away. And at that time, you probably need to send it to a specialist. And we do see a lot of these chronic long COVID things, and we are underdiagnosed in a way. And I've seen patients, coming and they have a cough or they have shortness of breath. The PFT is okay. But when I give them, put them empirically on an inhaler with a little bit of steroid to treat them for bronchiolitis, small airways disease that we see in COVID, and patients get better, actually. So, and it's not in their head. I think that they really get better.
Sure.
It's just that the tests are not perfect. Yeah.
Right.
The tests are not perfect. So, and we know from studies now from pathological data in COVID that, small airways problems, it can happen. And on CAT scans, I can see actually some bronchiolitis and small airways kind of air trapping and mosaic changes. And that's typical of small airways disease. And, when I see that change on the CAT scan, they tell me the symptoms and I put them on the inhaler or some other treatments and get them better. This is what it is. And ultimately, I want the patient to feel better.
Of course.
That's it. And then, I see them in follow-up, they're better, goodbye. Don't ever come and see me. I don't need to see you. If you're fine, you're fine.
Right. That's great. I can't believe we've almost been we're almost at the end.
I know.
Where
I
did
love
this time
Dr.
go?
Cojocaru.
It's great.
We just
I don't know.
joke and talk about
Yeah.
things.
No, we went.
Well,
We
you had
really
a great way
did.
of explaining
We
things.
did cover a lot of
Yes.
ground today.
Yes.
It
I
was
think
great.
this was very helpful,
Yeah.
to a lot of people, and especially the messages that we sent out.
Sure.
There's some education,
Yep.
Mhm.
and don't wait if you're don't try
Don't
to
wait.
Is there
Okay.
one story that sticks in your mind that you want to throw out there about a patient who came to you with shortness of breath that you're able to sort something out and make them feel better? Probably lots of them, but
Yeah, lots of them. But one thing, I remember this young 18-year-old that just turned 18, and she had difficulty breathing, and she had this chest tightness in the chest. And I asked, one thing when people come with shortness of breath and chest, especially shortness of breath, I do a walk test, and I remember I got with her. I said, "Let's go in the hallway." She was with her dad. And we started walking and talking, and I see the way she walks and the way she moves her body, that she has problems with her spine. So when I examined her quickly and, I did the walk, I'm like, let's make sure that, that you're not hypoxic. She was not hypoxic, but I, discovered this girl had thoracic cage problems, and she had scoliosis and a little bit of and the way she walked, and she had her hips and
she was out of
and she
alignment.
had out of alignment, and her thoracic cage was just, when I examined her more in details and I went on her back, and the tightness was basically from her rib cage being so tight around her chest.
Oh my God.
Yeah.
So what did you recommend
simple.
for her?
Yeah, I sent her for physical therapy.
And it worked?
Yes.
Yeah, that's great.
Physical therapy,
great story.
stretches, exercising, to stretch her back. I said, talk to your primary. Maybe they send you to a specialist. So to prevent, and these things, I have a good friend who has very severe scoliosis, had surgeries when she was a teenager. And, it gets worse over time. And you can get difficulty breathing, quite severe, actually.
Yeah, that's a tough one.
Yep. Especially when I see it in children. That's why they do actually now, what do they do in school and teenage kids? They do the nurse checks on everyone for
testing, yeah.
scoliosis.
Right. So is there one message you want to leave our audience as we finish up here?
One message is that shortness of breath is very common, and it can be nothing, but it can be a deadly disease. And asthma, as simple as it is, asthma still kills people, unfortunately. And I wish that everyone who has asthma and persistent symptoms, if they continue to have problems with their breathing, or they have recurrent, meaning 1 or 2 per year asthma attacks, they need to see a specialist, because that's very important to prevent deaths and to educate and to have a plan in place how to make sure that they know how to take care of themselves, to entitle the patient to be able to take care of their body and their breathing. Because that sensation of breathlessness, I think, is the worst thing that can happen to someone. Is like a fish out of water,
Yeah.
Is you wanting to get air and, being in the water, actually, or
Right.
being
Terrible
somewhere that you
sensation, I'm
cannot
sure.
do that. That sensation is not pleasant, and we don't want to feel that. I feel that, I think that any patient deserves the attention with shortness of breath. Yeah.
Yeah, it's funny. I do a lot of hospice work, and sometimes we have to admit patients to the hospital for uncontrolled symptoms. And everyone always thinks, well, it must be pain. When pain is a very common reason, but probably the second most common reason is shortness of breath.
And pain, we probably can withstand pain much easier than shortness of breath.
Yeah,
I think you panic when you can't breathe.
Yes,
of course.
that's right.
Yeah.
Yes.
So uncomfortable.
Yeah.
Of course. This has been great.
Thank you so much for
Really
having
appreciate it.
me.
How do patients reach you, by the way?
They can call our office, Primary Care Pulmonary or Lung Center. We do have a number. I don't remember.
That's okay. We'll post it later on.
Yeah, it's
So,
probably 508-789-4239.
okay.
I think it's that, but you can definitely reach out.
we can post that at a later time.
Yes,
That's fine. We'll
yes.
get that out there. So thank you very much. This has been really wonderful. It's
Thank
been a
you for
great
having me.
education on shortness of breath. I'm sure that our viewers have learned a lot. So I want to thank all of our viewers, of course. And if you are interested in becoming a sponsor, please contact us. 774-319-4230. Special thanks to Ron Gamache for our intro music, the PC Institute for producing our show, of course, Dr. Cojocaru for being our esteemed guest,
Thank you.
and Bay Coast Bank, who's just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. So you've seen, this is the 27th Degree with Chris and Nancy. Thank you so much for tuning in, and we'll see you back in another week or two. Take care, everyone.